It's Sunday night, and you're coming to the VA to begin your 2-week night float rotation. You walk past the ED and you see it's packed. Your suspicion was true. You get to the workroom, and there are 3 ED holdovers waiting for you. As you start listening handoff from the day team, you receive a page from one of the nurses in 3 North. A 9876 has arrived to the floor from Murfreesboro. Soft BP, please put orders and advise. Wow, reality check. You now have 4 holdovers.
Let's divide and conquer. You go lay eyes on Mr. A while I do a quick chart review,
Says your upper level. You find that Mr. A looks sick. He is in his 70s, he's somnolent, he follows basic commands, but is not answering questions coherently. He is disoriented. His BP is 80/60. He has a fever of 39.3 Celsius. His heart rate is 7 to 5. He is coughing and is breathing 26 times per minute and satting 88% on 4 liters nasal cannula. He has crackles throughout, no JVD, no peripheral edema. He is warm and his capillary refill is less than 2 seconds. You call your upper level for help.
I didn't learn much about Mr. A. He has not been seen here in 5 years. He has a history of COPD, not on home oxygen, CAD status post-remote cabbage, and type 2 diabetes. I could not find his hospital transfer documents, just one page that says that he was admitted 1 week ago for treatment of community-acquired pneumonia. He has been treated with peptazo and Vant for 7 days. I think he has sepsis. Let's give him a bolus of fluids, order blood cultures and respiratory cultures. Let's call ID to broaden to meropenem to cover ESBLs, and let's get labs and imaging.
While you start admitting your other 3 holdovers, labs come back showing significant leukocytosis with neutrophilia, lymphocytosis and eosinophilia, and thrombocytosis, normal troponin, BNP of 220, his previous baseline was 180, and urinalysis not suggestive of infection. EKG showed LV hypertrophy without ischemic changes, and chest X-ray showed multifocal consolidations on both lungs. It's midnight already, and you go back to the workroom to discuss the case with the hospitalist on call.
Hey guys, how's the night going?
Dr. C, I think we are getting mixed signals here. Something seems to be off with Mr. A. We cannot explain why he has not responded to broad-spectrum antibiotics for 1 week. And what the heck with this relative bradycardia with the fever? This patient is septic and is not tachycardic.
I think we should call a diagnostic timeout.
Absolutely. Let's start by stating the problem representation and naming the most likely primary diagnosis. Katie, do you want to give it a try?
Sure. Mr. A is a 74-year-old gentleman with history of COPD, not previously on home oxygen, CAD, type 2 diabetes, transferred from outside hospital after being treated for 7 days for pneumonia with broad-spectrum antibiotics, found to have pulse temperature dissociation, SIRS, hypoxia, leukocytosis with neutrophilia, lymphocytosis and eosinophilia, and multifocal consolidations on chest X-ray. I think the primary working diagnosis is sepsis from a respiratory source. I think his working diagnosis is still pneumonia, but just not a typical bacterial pneumonia.
Think that too. What doesn't fit with bacterial pneumonia?
Well, consolidations are multifocal, he has not responded to broad-spectrum antibiotics, and he has lymphocytosis and eosinophilia.
Agree. Also, the temperature pulse dissociation that you pointed out just doesn't fit with your typical strep pneumonia. What else could this be then? Let's prioritize our differential diagnosis. What do you think it's highest on the differential? Could there be multiple diagnoses or a complication of treatment?
I think we are treating the wrong bug and perhaps we need more coverage. We are not treating for atypical bacteria like Mycoplasma and Legionella or fungi. I think the most likely diagnosis is a pneumonia from an atypical organism or a complication of pneumonia like a lung abscess.
I agree with you, but let's not anchor too soon. What are some 1B do not miss diagnoses that could acutely affect our patient that we need to rule out overnight?
Well, he is not in septic shock. We ruled out pneumothorax, acute coronary syndrome, and cardiogenic shock. He is not in a RDS. His PF ratio is greater than 300. He could still have an empyema. We should take a look at his pleural space with the ultrasound.
Agree, even though he is stable right now, he is at a high risk of developing septic shock or RDS though. What are less likely and unlikely diagnoses in order of probability?
I think he could have a non-infectious etiology like eosinophilic pneumonitis or cryptogenic organizing pneumonia. He could have an infection somewhere else, like skin and soft tissues. We have not completely examined his skin. Less likely a parasitic infection like babesia or yellow fever, Rocky Mountain spotted fever, or COPD exacerbation.
I think that's a great differential. Let's make adjustments to our plan. What do you suggest, Dylan?
I think we should start a macrolide empirically to treat atypical bacteria, and let's get urine antigens for Legionella and fungi. Let's hold on steroids that would make an infection worse. Whenever we have some time, we should go examine his skin and call his family to get collateral information. Let's make sure that when we talk to the family, we tell them that we're not sure what his diagnosis is, and we do handoff tomorrow. Let's make sure we walk the day team through our thought process. Sounds like a plan.
As you just saw, the night team took a diagnostic timeout, and it just took them 3 minutes. The diagnostic timeout is a systematic 5-step process that helps you take a mindful pause in high-risk clinical situations to rethink and re-engage in the diagnostic process. The goal of calling a timeout is to optimize clinical reasoning, prevent diagnostic errors, and communicate diagnostic uncertainty to other members of the team and to the patient. We suggest you to call a diagnostic timeout during risky transitions of care like outside hospital transfers and direct urgent care admits. When patients present with altered mental status, they are non-English speakers or they are nonverbal when you examine them. Also, when you think you might feel overwhelmed with work. We tend to make more cognitive errors when feeling burnt out. You may also call a timeout when you feel uncertain of the diagnosis and when the patient is clinically deteriorating. Consider taking a timeout if you receive a page from nursing staff with a high deterioration score or if the patient has SIRS and evidence of end organ damage.
Now, it's time for you to learn how to call a timeout and implement it during clinical practice. Are you ready?